pertaining service development, cancer research, and education. Currently, Darmais Cancer Hospital is also developing a national program initiated by the Ministry of Health of the Republic of Indonesia, which focuses on collecting genetic information on patients and pathogenic microorganisms called the Biomedical Genome-Based Science Initiative, or BGSI. And to increase the capacity of cancer services for women and children, Darmais Cancer Hospital, with the support of the Islamic Development Bank, is constructing a woman and child cancer care building, an 18-floor, 3-basement building with the best facility and state-of-the-art services for women and children cancer treatment. Adhering to the creed and vision as a national cancer center, Darmais Cancer Hospital is completely dedicated to strive and provide the best cancer services to the people, nation, and the Republic of Indonesia. Become caring and smart National Cancer Center. National Cancer Center, Darmais Cancer Hospital. As Indonesia's National Cancer Center, Darmais Cancer Hospital continues to strengthen its role by providing high-quality cancer services, comprehensive cancer education, and research. By upholding core values such as professional, care, continuous improvement, and synergy, all elements at Darmais Cancer Hospital are fully committed to provide the best patient care and experience. Various in-house innovations are also being developed at Darmais Cancer Hospital to improve the overall quality of services. Darmais Cancer Hospital has been given a mandate by the Ministry of Health of the Republic of Indonesia to also become the National Cancer Referral Coordinator to ensure an even distribution of best practices in cancer care and treatment. Furthermore, we are also given the task to develop an international network of collaboration with other national cancer centers pertaining service development, cancer research, and education. Currently, Darmais Cancer Hospital is also developing a national program initiated by the Ministry of Health of the Republic of Indonesia, which focuses on collecting genetic information on patients and pathogenic microorganisms called the Biomedical Genome-Based Science Initiative, or BGSI. And to increase the capacity of cancer services for women and children, Darmais Cancer Hospital, with the support of the Islamic Development Bank, is constructing a woman and child cancer care building, an 18-floor, 3-basement building with the best facility and state-of-the-art services for women and children cancer treatment. Adhering to the creed and vision as a national cancer center, Darmais Cancer Hospital is completely dedicated to strive and provide the best cancer services to the people, nation, and the Republic of Indonesia. Become caring and smart National Cancer Center. National Cancer Center, Darmais Cancer Hospital. As Indonesia's National Cancer Center, Darmais Cancer Hospital continues to strengthen its role by providing high-quality cancer.
Mohon perhatian kepada seluruh peserta seluruh undangan. Acara akan segera kita mulai. Dipersilakan untuk mengisi tempat duduk yang masih kosong yang ada di depan. Sekali lagi kami persilakan kepada seluruh undangan, para peserta yang sudah hadir di auditorium lantai 1 Rumah Sakit Kanker Darmais. Mohon untuk bisa mengisi kursi-kursi yang masih kosong yang ada di depan. Terima kasih. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang, salam sejahtera bagi kita semua. Yang terhormat, Direktur Utama Rumah Sakit Kanker Darmais yang dalam hal ini diwakili Direktur Medik dan Keperawatan yang terhormat Ibu Dr. Eni Wigati, Spesialis Anak Konsulen. Yang terhormat, para pembicara, hadirin dan undangan yang berbahagia. Good afternoon, honorable speakers. Prof. Biju George, Senior Consultant, Clinical Hematology, Christian Medical College India. Prof. Rupert Han Grintinger, Senior Professor, Children's University Hospital, Tübingen, Germany. Ladies and gentlemen, welcome to Darmais Hospital, the National Cancer Center Indonesia. The international webinar host in partnership with Miltenyi Biotech, Advancing Graft Engineering in Pediatric Bone Marrow Transplantation, Innovation and Challenge will be commenced. Ladies and gentlemen, Bapak Ibu yang berbahagia, please stand for the Indonesian National Anthem, Indonesia Raya. Hadirin dimohon berdiri. Hadirin dipersilakan duduk kembali. Distinguished Bapak Ibu yang berbahagia, welcome to this official opening, the international webinar delivered by the Director of Medical Nursing. Please, Honorable Ibu Dr. Reni Wigati, Spesialis Anak.
Tapi masih tahun depan.
Assalamualaikum warahmatullahi wabarakatuh. Selamat siang, salam sejahtera untuk kita semua. Yang saya hormati, our distinguished speaker, Professor Dr. Bijou George, Professor Rupert Heinretinger, and the supporting team from Milpenny Biotech. Bapak Moderator, Dr. Nurul Aisyah, Spesialis Anak Konsultan, Ketua Ikatan Dokter Indonesia, dan Ketua UKK Hematologi Onkologi Anak Ikatan Dokter Anak Indonesia, para peserta hybrid seminar yang datang dari lingkungan Rumah Sakit Kanker Darmais maupun dari Rumah Sakit Kementerian Kesehatan, Rumah Sakit Umum Daerah, dan Rumah Sakit lainnya. To our distinguished speakers, we are deeply honored by your presence at today's hybrid seminar. Your expertise and contributions in the field of pediatric hematology, oncology, and bone marrow transplantation will significantly shape the global landscape of cancer care in Indonesia. And it is our privilege to have you here today to share your insights and your experience with our audience. So allow me to greet our audience in Bahasa. Bapak Ibu yang saya hormati, kami mengapresiasi kehadiran Bapak Ibu dokter sekalian dalam seminar hybrid ini. Salam hormat dan permintaan maaf dari Bapak Direktur Utama karena pada hari ini beliau sedang menghadiri agenda yang juga tidak bisa diwakilkan di Pulau Bali. Kami menyambut baik topik ini diselenggarakan pada hari ini karena untuk memperluas layanan kanker anak di Indonesia masih merupakan tantangan bagi kita semua. Di mana kita tahu Indonesia adalah negara kepulauan dan kita harus bisa memberikan akses yang sama terhadap anak-anak Indonesia yang terdampak kanker, tidak melihat dimanapun mereka tinggal. Dan selain meningkatkan cakupan secara keluasan cakupan, tentu menjadi tugas kita bersama untuk memastikan bahwa kualitas terapi yang didapatkan oleh anak-anak kita sama dan setara dengan apa yang mereka bisa dapatkan di negara pun di dunia ini. Kita lihat dari data bahwa angka kejadian kanker anak jauh lebih tinggi didapatkan di negara-negara berkembang seperti negara kita, namun survival atau kesintasan itu masih jauh lebih tinggi di negara-negara maju, dan tentu salah satu faktor yang mempengaruhi adalah bagaimana terapi-terapi canggih bisa didapatkan oleh anak-anak yang tinggal di negara maju. Kami berharap dengan sharing dari experts pada hari ini membuka lagi wawasan kita dengan lebih luas bahwa transplantasi sumsum tulang dan terapi sel lain sebenarnya bisa terbuka di Indonesia. Dan kami hari ini berharap Bapak Ibu bisa turut berdiskusi dengan bagaimana perkembangan layanan kanker anak di Indonesia, termasuk layanan-layanan canggih. Saya harap hari ini diskusi bisa membawa Indonesia menjadi lebih baik dan kita bisa memberikan layanan yang paling baik untuk anak-anak yang kita sayangi dan anak-anak yang akan menjadi masa depan bangsa ini. Terima kasih yang tak terhingga saya ucapkan sekali lagi untuk para pembicara dan juga moderator dan juga para panitia yang sudah berusaha dengan keras sehingga acara hari ini bisa berlangsung dengan baik. Dengan mengucapkan Bismillahirrahmanirrahim, saya buka dengan resmi webinar Advancing Graft Engineering in Pediatric Bone Marrow Transplantation, Innovation and Challenges. Selamat mengikuti. Wassalamualaikum warahmatullahi wabarakatuh. Saya ucapkan sekali lagi untuk para pembicara dan juga moderator, bagaimana para panitia yang sudah berusaha dengan keras sehingga acara hari ini bisa berlangsung dengan baik. Saya harap dengan mengucapkan Bismillahirrahmanirrahim, saya buka dengan resmi webinar Advancing Graft
Baik, hadirin yang bahagia, honorable guests, ladies and gentlemen, that concludes the opening remarks and formal inauguration by the Director of Medical and Nursing, Darmais Hospital. Our next features the presentation by our esteemed speakers. And as a moderator, please proceed with respect, Honorable Dr. Murul IC, Spesialis Anak, Konsulen. The floor is yours.
Yes. Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh. Thank you, Mr. Adian, for conducting this event. And good afternoon, ladies and gentlemen. And this is a very event, actually. On behalf of the organizing committee of Darmais Cancer Hospital, I warmly welcome you to today's webinar. Scientific webinar titled Advancing Graft Engineering in Pediatric Bone Marrow Transplantation, Innovation and Challenges. This event brings together experts in the field to share insight, research, and practical strategies for enhancing pediatric BMT programs with a special focus on graft engineering and immunotherapy. And we are truly privileged that we have today two world-renowned speakers whose pioneering work has shaped the landscape of hematopoietic stem cell transplantation. Professor Dr. Biju George from Christian Medical College, Vellore, India. Thank you, Prof. And also Professor Dr. Rupert Angretingers, Professor Emeritus from the University of Tübingen, Germany. Their contribution in areas such as T-cell manipulation, haploidentical transplantation, and cellular immunotherapy have significantly advanced our understanding and practice in pediatric oncology and transplant medicine. So I hope today's session will be enriching, thought-provoking, and serve as a catalyst for strengthening our effort in delivering state-of-the-art care to children with life-threatening hematological disease. Okay. Let's begin to our first session. I would like to invite Prof. Biju George to come forward. He currently serves as Professor of Hematology at the prestigious Christian Medical College, CMC, Vellore, India, one of the leading academic medical centers in South Asia. With over 2 decades of clinical experience, Prof. George has managed a wide spectrum of hematologic disorders, both benign and malignant, including acute leukemia, lymphomas, myeloma, thalassemia, plastic anemia, and inherited bone marrow failure syndrome. He has played a pivotal role in developing CMC's bone marrow transplantation program, which is now one of the largest in the region, having conducted over 3,500 transplants, including more than 750 for thalassemia major. Beyond his clinical work, Prof. George is a prolific academic contributor and reviewer for many high-impact journals, such as Lancet Hematology, Blood, and Hematologica, among others. His research has contributed significantly to advancing the field of transplantation, pharmacogenetic, and leukemia treatment in research-limited setting. Please join me in welcoming Prof. Biju George.
Thank you very much for that introduction, and I'd like to thank the organizers, Dharmesh Hospital, for inviting me to this webinar. This is my first visit to Jakarta, but as I was sort of traveling from the hotel here, it truly reminds me of home. It's no different from in between India and Jakarta, the way traffic is, I should say. There are motorbikes on the roads, but it's truly a memorable experience. Can I have my slides, please? Okay, so what I hope to talk in my first talk is just to talk about graft engineering in general. And before I talk about graft engineering, I would like to just talk about what happens in a transplant, what are the problems that occurs in a transplant, and why do we need graft engineering because the complex. Then in my second talk, I will talk more details about what do we do. Some slide. Of patient. But despite all the advancements that we have in allogenic transplant, there are still complications that occur. So when we look at what an allogenic transplant is, essentially there is a patient who needs the transplant, and that patient receives treatment to destroy the stem cells. Then you take stem cells from the donor and you infuse it into the patient. Unlike what happens in solid organs, here the infusion is just like blood. And over a period of time, these stem cells will home into the marrow, will settle down, produce new stem cells. And what we hope is that once they produce new stem cells, you are going to get a good immune system and a good amount of stem cells. And why is that? That is because it is the hematopoietic stem cells that actually form all the constituents of the blood. So whether it's the myeloid cells, which is your neutrophils, your monocytes, or your erythroids, which is your red cells, all your lymphocytes, all of it actually gets produced through the hematopoietic stems. And because these hematopoietic stem cells can get you a new set of cells which are normal because they belong to the healthy donor, you can treat a lot of diseases with this kind of transplant. So you can treat leukemia, you can treat bone marrow failure. In adults, we look at plasma cell disorders such as multiple myeloma. In children, children who have immunodeficiencies, you can actually replace the immune system, and more in terms of adults, non-Hodgkin's, multiple myeloma, myelodysplastic syndromes, and at the end, anemia, and that is something which we commonly see in India, which is hemoglobinopathies and thalassemia major, which is a big group, but there are also congenital disorders, Diamond-Blackfan anemia, congenital dyserythropoietic anemia. All these diseases can be cured with a bone marrow or a stem cell transplants because you're essentially destroying the patient's stem cells and replacing it with the cells of healthy cells. So when we look at the type of transplants that we generally do, we have a matched sibling donor transplant, a matched unrelated donor transplant, and third is a haploidentical transplant. Of course, the fourth, which was there, was cord blood transplants, but now probably it's slowly going down its way. Now, why is it important to know this? It's important to know this because to get an HLA matched sibling, which is usually a brother or a sister, you have about a 30 to 40% chance that you will find a donor within the family. Now, there are situations where you may find it within the family and not just the siblings alone. And that usually happens when you have communities which sort of marry within, inbreeding within communities, or you have a situation in India, what we commonly see is consanguineous marriages. So marriages between cousins, marriages between uncle, niece. If you have that, you have almost a 10% chance that you will find a donor from the parents or even from the grandparents. But that means of all the patients who need a transplant, only in about 40% will you actually find a donor. So what do we do for the rest where we don't find a donor, but this patient needs a transplant? And one of the ways is to look at registries. There are multiple donor registries across the world and where you can search. The general statistics is that there will be 1 in a million person who somewhere in the world has got the same HLA typing as you. So you can search through these registries, and if you do identify a donor somewhere across the world, you can actually use that donor for a transplant. Unfortunately, Asians are less well represented in the registries. They are more Caucasians. So, for example, from India, when I look for a donor, roughly about 20 to 30%, I would actually find a donor in any of the registries anywhere in the world. And that is where this big hype, not just the hype, the big practicality of doing haploidentical transplants have come out, where you need only a 50% match. Now, why is that important? It's important because for every child, both parents will be haploidentical because the child gets half HLA from the father, half from the mother. So they will definitely be haploidentical. You may have a sibling who's haploidentical. And if you are on the older side, you will have your children who will be half matched with you. So in general, more than 90% of patients who need a transplant will have an haploidentical donor. And that is why people are now looking to see how we can improve on haploidentical transplants because you have a large donor base available for each patient. Now, when we had talked to you about what happens to the transplant, so what happens after a transplant? So you've given this conditioning chemotherapy, you've given the cells, what happens after that? So they go through a period where they are neutropenic, roughly about 2 to 3 weeks. Most of them would stay in rooms like this, which are HEPA filtered rooms. This is a picture of one of our HEPA filtered rooms in our bone marrow transplant ward. And they remain in this period till the blood counts start to improve. And generally, we would expect that the neutrophils would start recovering between day 14 to 18. If you have a matched sib, may go up to 3 to 4 weeks. If it's a haploidentical transplant, the platelets follow after that. But importantly, and if you look at the right, the immune system in terms of the lymphocytes actually recovers much slower. And the immune reconstitution, even after a matched sibling donor transplant, may take up to 1 to 2 years. And there, if you look at all the different kinds, the NK cells come up first. But then if you look at the different kinds of cells, the T cells and the B cells, they actually improve slowly between 1 to 2 years after transplant. So though the blood counts are normal, they are still immunosuppressed for a period of at least a year. And that is the usual time that it takes for the cells that are coming up, which belong to the donor, to actually tolerize to the patient's body. Now, what happens because of all these problems? And right at the bottom, because of all these problems, you have problems of toxicity. So at the beginning, when you are looking at the initial 2 to 3 weeks, you are looking at infections because they are neutropenic. The counts are sitting at 100 or 0, and there are absolutely no neutrophils there. So they are at a risk of infections. They are at a risk of organ toxicity because of the conditioning chemotherapy that you've given, commonly being hemorrhagic cystitis or sinusoidal obstruction syndrome, which are side effects of the medicines or that we have given as a part of the conditioning. But as the counts recover, then you have these problems of graft versus host disease, where the donor cells that are coming up within the body recognize the patient's body as foreign and start attacking that. And that is what is called as graft versus host disease. And because these patients are on immunosuppression, at least for the first 6 months to 1 year, they are at a risk of recurrent infections occurring, both because the immune constitution is delayed and the cells that are needed to fight infection actually are delayed. So if you look at infections, depending upon which part of transplant you're dealing with, whether you're dealing with the time of engraftment, re-engraftment, or post-engraftment, you have very different kinds of infections that you can see. Early, you'll probably see more bacterial infections. In India, we see a lot of gram-negative infections, usually multi-drug resistant. That is usually in the beginning. As the counts recover, you will see more viral infections. So you will see cytomegalovirus, you'll see BK virus, adenovirus, and of course, if they are neutropenic, if they are on steroids, then we are looking at fungal infections that can occur. So as you go down the period, at least for the first 1 year, you are looking at different repeated infections that can keep occurring from time to time. So when we look at the complications that occur after a transplant, so right on top, you have graft failure. That means the patient's body has rejected the donor cells and you're back to the same situation as you were before transplant. You can have graft versus host disease, which is the other way, where the donor cells have come up, but they are reacting against the patient's body. You can have infections. Despite a transplant, especially when you're looking at malignancies, you can have a risk of relapse of the disease after transplant. You can have toxicity related to the conditioning regimen, and you can have a lot of immune-mediated complications that can occur in a transplant. So what should an ideal transplant be? Ideally, we need a transplant where there's 0% graft failure, 0% GVHD, no infections, no relapse, no toxicity, no other complications. Have we achieved it? No. Are we working towards this? Yes. And that is where a lot of scientific advancements in transplant have worked towards in terms of trying to reduce or at least minimize the risk of complications that can occur with a transplant. So there are a lot of expectations, but the reality sometimes is very, very different. So this is some data from the US looking at transplants in children. And so what you can see on the top, if you look at the blue line, actually is the numbers that are steadily rising up. Those are haploidentical transplants in children who are having multiple diseases. Then, of course, there is matched sibling donor and matched unrelated donor in the dark green and then in the magenta color. So what is happening across the world, and it's not just the same happens in Europe, the same happens in India, that because of the advent of haploidentical transplant, the number of transplants have actually steadily been going up because now there is a donor available for almost every patient who needs a transplant. And when we look at what happens in haploidentical transplants in children, If you look, the common indications are acute lymphoblastic leukemia in the blue line and of course acute myeloid leukemia. These are the two largest indications for transplant. Now, when we look at what are the common diseases, ALL, AML, in between you see primary immunodeficiencies, aplastic anemia, sickle cell disease. So what I said right at the beginning, both malignant and non-malignant diseases all can be cured with a transplant. Now, we are looking at having no graft failure, no GVHD, no relapse, so everything should be well. But when we look at reality, it is actually very different. And this is patients, children and young adults, so up to 18 years, AYAs. And there we are looking at, this is an AML. So you have roughly about a 60% chance of cure if you are in first remission, almost 60% in second remission. And if you have got refractory disease, you are looking at about 20%. With unrelated donor, it's about the same. If you're looking at ALL, it's better. So you're looking at about 80%. If you're looking at CR1, CR2 is about 70% and not response, it's less. So we are there somewhere, but ultimately we want to reach 100% because we would like every child who has a transplant to be cured. So if you look at the causes of death, and this is again the causes of death in young patients. So I have put that in the purple. Main causes are organ failure, relapse, infections, GVHD, and graft failure. So what we talked about are the complications. Some of them actually result in mortality. So trying to improve that or reduce that will help us in reducing mortality and thus improving overall survival. So how do we reduce complications? So like I mentioned, there are two important aspects to it. The first is the chemotherapy. Now we know that we have to give chemotherapy, which could just be drugs alone or radiation. And two, once we do that, we infuse these cells back into the body. And what does each of them do? So chemotherapy or plus minus radiation, we use it to make space within the marrow to allow the stem cells to be accepted. We may in addition use drugs to suppress the immune system of the patient, again to help the cells to be accepted. And the problems that occur if we use too little chemotherapy, you have graft rejection. If you use very intensive chemotherapy, you have regimen-related toxicity. So you try to strike a balance between graft rejection and regimen-related toxicity. So there are now reduced toxicity conditioning regimens, which are aimed at destroying the marrow, but are less toxic. We look at appropriate conditioning for disease. So that means every disease does not have the same conditioning. Whether it's AML, ALL, thalassemia, aplastic anemia, you have specific conditioning regimens for each of them. And of course, even though you have that conditioning regimen, sometimes you modify the regimen based upon the condition. So if you have a patient with aplastic anemia who's got a bad infection and it's not coming under control when you're taking up for transplant, the conditioning regimen may be different. Similarly, if you have a patient with acute leukemia who's in remission versus a patient who you're taking up with some amount of disease on board, the type of conditioning may actually be different for both of these patients. Now, what we saw in that second one is the graft. What we need is the CD34 positive cells. Now, these CD34 positive cells are the hematopoietic stem cells, and they are needed for adequate engraftment. The T cells are needed for immune reconstitution. Of course, the problems that we have is graft versus host disease, relapse, and infection. So it's very important for us to try and identify and understand the roles of the various cells in the harvest and then see if they can be manipulated. So this is the sort of a pictorial representation of the different cells that we have. On the left side, you have a CD34, which are hematopoietic. What you have a majority, especially in a peripheral stem cell harvest, are your T cells. So you have a CD8 positive T cells, CD4 positive T cells, you have a gamma delta, NK T cells, you have a natural killer cells, B cells. So all of this is mixed in either the bone marrow or the peripheral blood that you're actually going to infuse into the patient. So if you look at each of the cells, so CD34, it's important for reconstituting hematopoiesis, and the number of CD34s that you infuse actually has an impact on neutrophil and platelet engraftment. So you have to make sure you're giving an adequate number of CD34 positive stem cells when you're giving the harvest. So when we actually measure out a harvest and give it, we go by the CD34 because we have to first ensure engraftment. The rest of it comes in along with it. The B cells are important for immune reconstitution and production of antibodies and protect against viral infections. The dendritic cells, both host and donor cells, are important, both in immune reconstitution, but they also play a part in initiating graft versus host disease and the graft versus leukemia effect. And NK cells are important for immune reconstitution, for protecting against infection and cancer, reducing GVHD and for GVL. Why do we need to understand each of them? Because now we have the potential to try and manipulate the harvest in such a way that only the ones which are important for us can be infused, and the ones which are not important for the patient can actually be removed. So even when we look at the CD8 positive, that are the cytotoxic T cells, they are the main killers of infected cells and cancer cells, important for graft versus tumor effect and helps in promoting tolerance, while the helper T cells coordinates immune response and activate other immune cells. The gamma delta T cells are important in engrafting and immune response, while the NK T cells are important for immune reconstitution. So you see that each of these cells actually have different roles to play in the body after a transplant. Some of it good, some of it not so good, some of it actually mixed, because in some things they do well, while in other things they actually propitiate or cause things like graft versus host disease. So we need to prevent graft rejection. So we need to make sure that there are adequate CD34 cells. Usually we keep for an allogenic is about 3 million cells. Lower doses are associated with graft failure. Very high doses are also not very good, because when you give high doses, along with that, you're giving a lot of T cells. And so because of that, you end up getting higher incidence of graft versus host disease. Now, this prompt engraftment is important, especially in developing countries, because the longer it takes to engraft, you will end up having more bacterial infections and fungal infections. So the time to neutrophil engraftment becomes better when you have more CD34 positive cells. Now, graft versus host disease occurs in 30 to 50% of transplants. The question we would naturally ask is, in a matched sibling donor, we know that the HLA is matched. Now, if the HLA is matched, why does graft versus host disease occur? We believe that it occurs mainly because there are a lot of minor antigens within the body, which is different between the patient and the donor. The only way the minor antigens is similar would occur when you have a twin transplant. So if you have an identical twin who's donating, everything will be normal. Otherwise, they will be abnormal. And so despite having a 6x6 or a 10x10 matched donor, you still would get graft versus host disease. And the GVHD is higher when you're dealing with unrelated donor transplants, or in patients who have a haploidentical transplant where we know that the HLA is only half matched. Now, so because we know that GVHD occurs despite being a full match, we generally try to control the GVHD with pharmacological measures. So generally we would give calcineurin inhibitors, either cyclosporin or tacrolimus, or mTOR inhibitors like sirolimus, in combination with other drugs like methotrexate or mycophenolate mofetil. You would start between 1 to 4 days before the infusion, and then you give it for about 6 months full dose and taper it and stop it by a year. So unlike solid organ transplants, where generally immunosuppression is needed to be given lifelong because to prevent graft rejection, in bone marrow transplants, we believe that tolerance is usually achieved by about 1 year. That means the body recognizes the donor cells as self, and the donor cells recognize the body as self. And when that happens, they no longer react with each other. And so roughly in about a year's time, you should be able to stop it. If you do not stop it and there is prolonged immunosuppression, it increases the risk of infection and it increases the risk of relapse of the original disease. So there comes the question. So we have that harvest with all these cells. Are we able to either inactivate or remove some of the cells which we don't want for a transplant process, which causes problems? Now, like I mentioned, the stars are the haplo and the mud, which are steadily going up. These are the ones which have a higher incidence of graft versus host disease. And the haplo is really taken on because there's immediate donor availability. For every child, the parents can serve as a donor. And for older patients, 80 to 90% chance that either siblings, parents, or children will actually be haploidentical. It's got a quick turnaround time, so you can actually quickly work up the donor and take them up for a transplant. Remember, in a mud average, you're looking at least 2 to 3 months from the time you identify a donor to actually getting the cells for a transplant. So it is a big process of trying to keep the disease under control till you can actually do the transplant. And very importantly, the donor is available for a second graft in case the first does not work, there's graft failure, the donor is available. Or post-transplant, if you decide to do donor lymphocyte infusion or other immunotherapy, the donor is available. So when we transplant across HLA barriers, that means it's only half match, 2 major problems occur. One is there's an increased risk of rejection, and there is an increased risk of graft versus host disease. Rejection because it's only half match. The patient's body will recognize the donor cells as foreign, will attack it, destroy it, you get graft failure. But on the other hand, when the cells come up, the donor cells will react against the patient's body because again it's half match and cause more graft versus host disease. So how can we try and solve the problem? We can try and increase the CD34 dose in the graft that will help reduce the graft rejection. And we have to try and reduce the T cell dose in the graft, and that will reduce graft versus host disease in patients who are undergoing a haploidentical transplant. So when we have to decrease T cell activity, what can we do? We can either look at, can we add on more drugs to what we are already giving, that is the calcineurin inhibitors with methotrexate to try and reduce T cell activity, or can we do graft engineering? So the 2 common things that people do now to reduce T cell activity, one is to add what a drug called as anti-thymocyte globulin or anti-lymphocyte globulin. This is basically prepared by immunizing horse or rabbits with thymus obtained during surgery. So human thymus you inject in, what happens? These rabbits and horses will produce a lot of anti-T cell antibodies. And these anti-T cell antibodies are purified, refined, and then used. They are generally polyclonal. You can also get it from cell lines like the Jurkat cell lines. And there is clear data to show that if you actually, in mud transplants, if we use ATG, you reduce the risk of graft versus host disease. The problem is the ATG will kill all the T cells. It's not going to selectively look for specific T cells. When it starts killing all T cells, your immune reconstitution is low, and so your risk of viral infections actually goes up. But with some, there is no increased risk of relapse. The second which has come up is the use of a drug, which is a very old drug, cyclophosphamide, which was used post-transplant, especially in haploidentical transplants. And this was given on day 3 or 4, essentially because cyclophosphamide will kill alloreactive T cells. Now, these alloreactive T cells, so the cells after a transplant which are proliferating very fast, have low levels of ALDH1 or aldehyde dehydrogenase 1. When they have low levels, they are sensitive to killing by cyclophosphamide. But memory T cells and stem cells have very high levels of ALDH, and so they are resistant to cyclophosphamide. So when you give cyclophosphamide on day 3, day 4, you are trying to kill off the cells which will actually cause graft versus host disease, while you're hoping that these memory cells will remain and later help in immune reconstitution. Now, when you do that, there is data again to show that you can reduce graft versus host disease. It was initially done in haploidentical transplants, but now it's being increasingly used in matched unrelated donor and in matched sibling donor transplants to reduce the risk of graft versus host disease. And so people are now actually looking at combining the ATG with the post-transplant cyclophosphamide to try and reduce the risk of GVHD. Now, what are the problems? The problems are that these, because they are not specific, they knock out all T cells, most of the T cells. And so because of that, you end up getting poor reconstitution, so more infections. GVHD is still not very low. It's come down to 10-20% in different series, but it's still there. So the question is, can we go beyond pharmacology and address the harvest of the graft to try and see whether we can reduce or manipulate the graft to reduce graft versus host disease? And that I will do in my next talk. With this, I will stop. I understand that the questions are at the end, and I will hand over. Thank you so much.
Thank you, Prof. Biju. And this is very interesting topic and nice present, and you show us about graft engineering for clinician and what everybody pediatric oncologist needs to know. And as we know, we have here our colleagues, pediatric oncologists from among institution in Indonesia. So for the next speaker, I would like to invite Prof. Rupert Hengretinger. We are already familiar with him because our transplantation, the first transplantation in Darmais, and has collaborated with also Cipta Mangun Kusuma Hospital and Harapan Kita Hospital, helped by him in so it is read the curriculum vitae. Professor Dr. Rupert Hengretinger is renowned expert in pediatric hematology, oncology, and stem cell transplantation, and his clinical and research contribution have significantly advanced the field of haploidentical stem cell transplantation. From 2000 to 2005, he served as the director of the Division of Stem Cell Transplantation at St. Jude Children's Research Hospital in Memphis, USA. Since 2005, he has led the Department of General Pediatric and Hematology Oncology at the University Children's Hospital Tübingen and served as its medical director. Among his many accolades, Professor Hengretinger is a recipient of the State Research Prize of Baden-Württemberg, the Robert Pledger Research Award, and the Lifetime Achievement Award from the Pediatric Transplantation and Cellular Therapies Consortium. He is also a member of the German National Academy of Science Leopoldina. So without further ado, Prof. Rupert, please come forward, and he will talk about the managing GVHD in pediatric BMT, insight and technique for emerging centers. The floor is yours.
Thank you, Dr. Rishi. Thank you for inviting me and giving me the opportunity to discuss some of the aspects. Fortunately,
Oke, ya. Tapi hari ini belum begini nih.
went with you
Oh,
through
boleh pulang.
problems of transplantation and
Kenapa? Gimana?
Ya, ini
Ah.
kan dok,
Minggu ya.
udah ini juga pastinya kan.
Udah nggak
when you
betah.
do it with presentation mode,
Udah,
Tapi sudah koordinasi ke bagian keperawatan.
udah sahur kemarin katanya udah saya besok pulang katanya.
Let's show.
Mhm. Iya.
Kemarin dia jam 1 udah datang.
okay.
Iya, dokter Sahar itu sebenarnya nggak terlalu banyak juga Pak. Tapi cuman ya karena beliau bukan full di sini, jadi akhirnya bisa lebih lama.
Dari
Coba
sana?
nanti kita ambil ya.
Pak,
bocor Pak.
Maybe
Okay, I think, okay.
pendamping itu
So,
sampai.
Dr. Fisher has already showed you that allogeneic transplantation go into the donor issue that has been showed already by Dr. Fisher. Just to repeat shortly, we do our conditioning for the myeloablative, non-myeloablative therapy, and
Dari dokter Sahar.
Lewatnya
patient is therapy.
siapin.
A lot of therapy in the patient, and we hope I think in the future we need to do something better. But this is for the moment, but it's not smart.
Ntar kita dulu
Why
ya.
not do
Oke,
it?
tadi ya.
And I show you why. And then we have the graft, of course, with the stem cells.
Mau rencana apa? Mau rencana apa?
Stem cells. These
Oh,
stem
mau
cells are
pulang.
enough. All the other cells, which Dr. Bishu will also make a future, are helpful.
Yang dulu ya. Masihnya ya.
Very helpful and are damaged.
Untuk yang online tolong di mute Mas Iwana, tolong supaya nggak bocor.
Okay, can you hear me now? Sit forward. Exogenous terms, but we can avoid our internal terms. This is something we can try to reduce, but it all together when we do the transplant. And the Vishu has already shown what are applications. The complications, we have the fungal infection, we have virus infection, and then we have also some problems with the lung. We have the bronchiolitis, and unfortunately, we have seen this side very in reality here. Patient which was transplanted here. We have the idiopathic pneumonia syndrome. These are all things which we really don't yet understand completely what these are. Maybe, and we have the SOS or veno-occlusive disease, sinusoidal obstruction syndrome, and I want to focus today on the acute and chronic graft-versus-host disease. Of course, this is something which is a obstacle in transplantation, and it can be quite very challenging to treat graft-versus-host disease. Once you have it, of course, we try to avoid it, as Dr. B shown you, with various pharmacological methods, but we still have patients who get it, and then we stand for the problem, how do we treat graft-versus-host disease? This has been shown. This is acute graft-versus-host disease. This is a very typical, the palm. So here, the solar is a sometimes sharp range, but it's more. It can even get very like a burn if it's affecting the skin. And we classify graft-versus-host disease. There are a lot of classifiers now. This is the easiest, maybe. We have normally the acute graft-versus-host disease is classified as it starts in the first 100 days after transplantation. Of course, we can have also a late onset acute graft-versus-host disease. This is different from chronic. I'll show you later. And we have an overlap syndrome where you cannot exactly say what is acute and what is chronic graft-versus-host disease. Okay. Okay, this is another staging of the graft-versus-host disease. It's a little bit more in detail because it depends on the organs which are involved. And mainly we have three main organs involved in acute graft-versus-host disease, which is the skin, which I showed you already, which is the liver, and which is the GI tract. Of course, skin we can see. We can have the maculopapular rash, and then we can, according to this, we can stage the graft-versus-host disease. It can be up to stage 4 at very generalized erythroderma and bullous formation up to desquamation, which is quite like a burn, like a burn. And of course, we have the liver where we measure mainly the bilirubin, the direct bilirubin. And of course, in the GI tract, we measure the output, the stool output. And you can have in severe GI or gut graft-versus-host disease in children up to 5-7 liter output per day is not unusual in a high grade. And this is, of course, a big problem to treat also for patients and to live with this. Again, here's some pictures of the clinical manifestation. Of course, this is still the maculopapular rash, but it's then more severe. And these sticks, they get infected. Remember, we have all bacteria on our skin, which we have, which is normal. But if your immune system is not there, these infections will start to and this is something, of course, then we don't like to see, and we try to avoid this, but we never can to avoid graft-versus-host disease. Of course, if we are not sure, then we do a biopsy, and some of the biopsies are then very typical of the skin. This is most easiest to do a biopsy of the skin. Also, the pathologist can grade it also from vacuolation up to the necrosis formation. And you can see here how the skin is infiltrated by lymphocytes, which causes this graft-versus-host disease. In the liver, sometimes it's not clear whether there is graft-versus-host disease. If the bilirubin is high or the transaminases, it can also be CMV infection. Sometimes it's very difficult to GVH, what is infection? Sometimes it's both. Sometimes it's the treatment of GVH, which causes infection because it's immunosuppressive. Then we do a biopsy, and then sometimes the pathologist can see that there is a small bile duct damage. So it's a disease of the bile duct, the liver graft-versus-host disease. That's why the direct bilirubin is a good marker, and gastrointestinal GVH also shows loading crypt. And a lot of the crypts also, as you can see here, with diffuse infiltration of lymphocytes in the gut, as you can see here, and this leads to this diarrhea and this extreme high output of intestinal fluid like water on a daily basis, which is very difficult to manage just to keep up with the fluid maintenance of these patients. And still, if you have graft versus host disease is still the major cause of late non-relapse mortality. Of course, we have relapses as underlying disease in malignant diseases, and GVH, the higher grade GVH, as you can see here, the grade 2 to 4, according to our grading, which I showed you, is still associated with a mortality of up to 30 or more than 30%, as you can see here. If you have a low graft versus host disease, so grade 0 to 1, the mortality is poor, but the higher grade, starting from 2 to 4, is quite high and associated with a higher increase of mortality. And what are these patients dying from? This is a paper where they looked at patients who died 1 year after transplant. Half of them had, not almost half of them had a relapse of the underlying disease, and the non-relapse mortality was also about more than a little bit 50%. And you see among those who had a non-relapse mortality, 20 of these 24 who died had a graft versus host disease 2 to 4. So it's quite high. It's not only the graft versus host disease which you die from. Often patients die from the treatment of the graft versus host disease because we come up with a lot of immunosuppression, and we have already a patient who has an immunosuppressed hematopoiesis by the transplant, and then we additionally suppress the immune system to treat graft versus host disease, and that causes a lot of infectious problems, and patients not actually die from a red skin. You don't die from a rash of the skin, but you die maybe from the too intensive treatment if you give too much steroids or too much other drugs. And then you get the infections, mainly also bacterial, but also we see fungal infection with too much exposure of cortisone or steroids for these patients. But you have to do something, of course. Otherwise, skin is still okay, but liver and gut, you cannot leave the children or the patients with 5 to 7 liter fluid output a day, or you cannot have them with liver failure, which ends up as the problem of the patients if you don't treat liver GVH with liver failure. So this is the GVH prophylaxis, shortly mentioned. We have the conditioning, which can differ, of course, from TBI to very myeloablative to less intensive. But this is the backbone, cyclosporin mainly, or calcineurin inhibitor. This has been shown by Dr. Bishu, MMF, mTOR inhibitor, methotrexate, ATG, and post-transplant cyclophosphamide. But despite we do this all and we try to avoid graft versus host disease, we still have patients who get it, and these therapies are not preventing graft versus host disease. And just one is very important also, and this is shown here. You have to really adhere to this prophylaxis of GVH. This is a paper showing the cyclosporin level done after in the first days, how important if you underdose and you do not measure cyclosporin level and you need to have it rapidly. So it's not enough to do cyclosporin level and get the results in 2 weeks. No, this is often in some problem in some centers. You have to do it and to get the results because it's important. You can see those patients who have a low cyclosporin level here below 150. The graft versus host disease grade 2 to 4 goes up significantly compared to those patients who have a normal, quite appropriate CSA cyclosporin level. So just these minor things are very important in these transplantation settings, and you really have to go after these minor things. Or if a patient starts to get bilirubin increase, you have to go after it and see what is this. Or patient starts to have more diarrhea, you cannot wait for days. You have to go after it and check, is he developing graft versus host disease? The earlier you catch it and you treat it, the more the probability that you maybe can contain it or you can treat it. Because once it's there, then you have a problem if it's responding. The first, what we do when we have graft versus host disease, we give steroids. And normally The current dose is 2 milligrams per kilo per day. I think this is the standard. There have been also advocates giving higher doses of steroids, up to 10 milligrams per kilogram per day, prednisolone. But then it has been shown it has no addition in the terms of transplant-related mortality. So the higher dose is not more effective. Normally we think the more the better, but not here in steroids. Maybe the more it causes more infections if you give too much steroids. And also, the steroid response is very important. These are patients who respond very nice after a few days of 2 milligrams per kilogram steroids. As you can see here, the mortality is quite low. So this patient is a very good responder to your therapy. The problem comes if the patient is a non-responder. So after day 5 of 2 milligrams per kilogram steroid, don't see any response in your GVH, you have a problem. And this is your problem, that the mortality is quite high. This is a higher grade graft-versus-host disease. This is how we define steroid refractory graft-versus-host disease. There are some criteria from the EBMT, NIH, which can all be read. This is the biggest problem if you have progression of GVH despite steroids. You start initially with this 2 milligrams, some centers would give more, or you have a failure to improve after a week of steroids, or there is only an incomplete response after more than 28 days of immune suppressive therapy, including steroids. Maybe in the meantime, we have also added another one, other agent like MMF, mycophenolate mofetil, or something else, or sirolimus. Do your regimen and the patient is still not responding. These patients are steroid refractory patients, and this is causing the problem in the transplant setting. This is the also a paper. This is the overall survival after steroid refractory GVH, and you can see here how the curves after 4 years. This is of course quite a big problem if you don't treat it very early and aggressively. I think this is also very important that you be really aggressive with treatment, very early treatment, to avoid this outcome, as you see here. Of course, then we don't have to go into details. This is just to show you, because then when you have this steroid refractory GVH, then you have a problem. And then people try a lot of different things, as you can see here, from ITG, daclizumab, etanercept, all the new drugs which are coming in combination with prednisolone as your first-line therapy to try to contain the GVHD. And of course, this is always a multi-modality treatment. You always have more drugs than one, so it's very difficult in GVH which drug is helping. Some patients have 5 drugs to treat GVH, and how can you know whether drug 1 or drug 5 is the one which helps you? So that's why there is so many out there, different approaches, because nobody can really say this is the most effective. Maybe there is one which I show you a little bit later. But patients with steroid refractory graft-versus-host disease, this is where they have added then, for example, etanercept, MMF, and you see there was not really a big improvement if you have steroid refractory, especially if you have a higher grade, like here, grade 4 GVH. Almost all these patients will die from their GVH or from the treatment, namely from infections. So this is a huge thing that we have to try to avoid graft-versus-host disease, or treat it very early in the beginning. This is then second-line therapy. This is when the first-line therapy is not working. Your problem gets more and more by the day if you have the patient in front of you. Then you try a lot of other things. You add methotrexate from whatever you have, whatever is approved. Also sometimes Campat, alemtuzumab. Horse ATG has been already mentioned by Dr. Bishu. You try combinations in all these ATG again. So there are so many studies out there. And this shows you a little bit the problem, that the more studies out there with different combinations, the less we know which combinations are really doing the best. Otherwise, we only would have made 1 or 2 studies. But this shows you that there is a lot what we have to do. And to understand GVH, I think this is also very important. Of course, it's the activation of the T lymphocytes. Now there is different approaches now. There is this abatacept, also quite new, which blocks CD28. This is a receptor which activates lymphocytes. We have the ATG. We have other antibodies, very more newly antibodies, which block cytokine receptor and so on. Of course, we have the calcineurin, the tacrolimus or cyclosporin here. We have the sirolimus as an mTOR inhibitor. We have the MTX, MMF, but I think the most more recent development, and I think this is one, is this ruxolitinib, and this is a JAK1, JAK2 inhibitor. This JAK1, JAK2 are phosphorylases, which are very important when cytokine activate the T lymphocytes. These JAK1 and 2 are activated, and they lead to downstream activation of T lymphocytes and proliferation. So the idea is when we inhibit this JAK1 or 2 with this little drug, ruxolitinib, then maybe the GVH rate might go down and the T cells are less active. And this has been studied, especially by Robert Seiser from the University in Freiburg in Tübingen. That was in the adult study, the REACH2 study, where they used this ruxolitinib for steroid refractory acute graft-versus-host disease. And I have shown you already how bad the outcome is of steroid refractory graft-versus-host disease is. They randomized these patients, one in the ruxolitinib arm and one they got kind of standard of therapy. That means a wide range of different immunosuppressive therapies. And then they did the analysis. And to the surprise, I think, of all of us, that ruxolitinib was very effective. This is the complete responses, and this is partial responses in day 28. And this is the durable response at day 26. And you can see that the ruxolitinib was quite significant, led to a better control of the acute graft-versus-host disease, which was steroid refractory. So that was, in my view, a major breakthrough in treatment of acute steroid refractory GVHD. And interesting, patients were already more than 12 years of age. So there was experience in this study with some children already. And I show you this later. And this is the outcome of the same paper. As you can see here, the patient with glucocorticoid refractory GVHD had a much better outcome with the ruxolitinib compared to the control group. And that led to the approval of the ruxolitinib named Jakavi for the treatment of acute graft-versus-host disease here for the patients older than 12 years of age. This was this study by the Seiser group. And then there was the REACH4 study for pediatrics, which is important for us as pediatricians, of course, where the same was treated, even naive. So treatment naive GVH and steroid refractory acute graft-versus-host disease, as I showed you. And the results were very similar, that even with steroid refractory graft-versus-host disease, there was still a good response to ruxolitinib. And also, as you can see here at 28, either the treatment naive had a very good response. So they got ruxolitinib very early, but also those patients who had a steroid refractory graft-versus-host disease still had a very good response, either complete response, but also partial response, which was also very important. And even if you go to the organs, the best response was skin, then the upper GI, lower GI, and also liver. So this is very important drug in the pediatric transplant setting to treat graft-versus-host disease. And that led also now to the approval of Jakavi or ruxolitinib for children. This is the dose recommendation here, which can be read in this paper. 10 milligram twice daily, like in the adult dose, and then smaller children with less dose. There are not yet doses recommendations for children lower than 2 years of age. This is still something which people work on, but Jakavi has changed a little bit how we see GVH now. We are not that anxious anymore. I think since we have this in mind, of course, it has some side effects which you have to observe as any other drug, but this has been really a breakthrough. Another treatment of graft-versus-host disease is this one. We also have mesenchymal. These cells, which helps also to get to control graft-versus-host disease. Of course, this is a little bit more invasive procedure because you have to hook up the patient to an extracorporeal machine, to a cell separator. We use the Terracos machine, and I'm looking. Yes, and then we in pediatrics we tested this extracorporeal photopheresis. I was part of the study, as you can see here. And we also see some results in acute graft-versus-host disease, steroid refractory with this extracorporeal photopheresis, and half of the patients still got into complete remission using this approach. But I have to admit it's quite cumbersome to do. You have to do it 1 week for over 6 months or times a week to hook them up on an extracorporeal machine. So if you have other means like the Jakavi, I think maybe more smart to try Jakavi first before going to this very specialized method. No, maybe the battery is empty or. Okay. And just recently published also by the colleagues from Freiburg, here from Robert Seiser group, they have combined this extracorporeal photopheresis with the ruxolitinib, with the Jakavi, and also have shown that they see additive effects if they combine it. As you can see with ruxolitinib alone, the day 28 response was 71. If they combine it with extracorporeal photopheresis, it goes up to 96%. And if you wait longer, The response after 1 year in this small cohort of patients, I have to say, was quite dramatic. Ruxo alone, 33%, 92 still with the combination. So it might also something in very refractory GVHD, acute GVHDs, that you combine this extracorporeal photopheresis, if you have it, of course, with ruxolitinib. Okay, that leads me to again show you acute GVH is a quite complex activation of the immune system, but in almost all cases, acute GVH leads to chronic GVH. Chronic GVH alone is extremely rare. You always have before acute GVH, then goes over to chronic GVH because of all these dysregulations of the whole immune system. And this is chronic GVH. It's a little bit, it's a different acute GVH. You have other components of the immune system which are not working, but the most important is what Dr. Bishu already mentioned, and this is chronic GVHD. This is chronic GVHD. It's, as you can see here, this is scleroderma. This whole patient is affected, and you can imagine these patients, they got every therapy you can add, and despite this, they had this disease. This is like scleroderma. This is also a severe chronic GVHD. This patient did not survive, this patient of mine. So this patient, this is not survivable because this goes from one infection to other. This patient is doing well, but you can imagine his quality of life is not that good, it's impaired. So this is why we have to do all to avoid this. And chronic GVH, we can also do grading. Mild is a number of involved organs and the severity of the involved organs. And one problem of chronic GVH is the lung. Chronic lung GVH, and this is maybe what has been seen in our patient here, which then goes maybe into this bronchiolitis obliterans or this bronchiolitis with BO or with organizing pneumonia or in the pneumonitis. We call it idiopathic pneumonitis syndrome, but idiopathic means we have no idea what it's caused. You know, it has a nice name, sounds very scientific, idiopathic, but behind this, we have no idea what's going on. And that's also the problem, that we don't know how to treat it since we don't know what's going on. And that, I think, was one of the problems. And chronic GVH, and this is what Dr. Bishu mentioned, that in transplant, bone marrow transplant, you get tolerance. Maybe after a year, you don't need any immunosuppressive drugs anymore, in contrast to organ transplantation. But if you have a chronic graft-versus-host disease like this patient I showed you on the whole body, there was a failure of immune tolerance. This was never achieved. So this is a chronic rejection or attack of the donor hematopoiesis against the patient, leading in all this. And this has to do with the thymus also again, how the thymic and new T cells from the donor in the thymus learn to accept the recipient as self. So this is a huge problem also, and also very, very difficult to treat. What are the risk factors? The main risk factors are, of course, if you have a mismatched donor, you might have more risk of GVH if you use peripheral stem cells as a donor source in pediatrics, because there are more T cells in the graft. Female donor into male recipient might be something, but the strongest is the severity of acute graft-versus-host disease. Unfortunately, this is rarely happening in younger children below 12 years of age, fortunately, compared to adults. I think this is somewhere we are a little bit in advantage. Of course, this is the first line treatment of graft-versus-host. I think my time is over. Just to give you also, then an overview, we start with a lot of medicines to treat this. We don't have to go into the detail. Second line treatments, but also here, these are the FDA approved treatments for graft-versus-host disease now. The newest one was this belumosudil, the ROCK inhibitor, but also the Jakavi. As you can see here, the ruxolitinib is very important. This one is approved. Ibrutinib is a B-cell receptor inhibitor. BTK inhibitor is approved for children. These are still yet for older 12 years, but most pediatricians use it outside of this age indication. But the best is, of course, to prevent graft versus host disease. And this is what Dr. Bishu will show us in the next talk, how to prevent it and just maybe remove this causing graft GVH causing T cells from the graft. And with this, I thank you for your attention and sorry for this, whatever happens. Thank you.
Thank you, Prof. Rupert. And yeah, you may have a seat here. Yeah. And then that's we learn the complexity of GVHD. From acute GVHD can lead to chronic GVHD based on acute inflammation and then dysregulation of T cell, B cell, and then finally fibrosis, something like that. And then this is more exciting to learn because Prof. Biju will talk about the evolution of graft engineering, ex vivo T cell manipulations, yeah, especially how to reduce the risk of GVHD. Please, Prof. Biju.
Thank you. Can I have the slides, please? So, Dr. Rupert actually eloquently presented what happens with acute graft versus host disease, what happens with chronic graft versus host disease, the pharmacological therapies available. One of the things we realize in all of it is that everybody who gets acute GVHD does not get cured. There's a certain amount of mortality that is associated with both acute and chronic graft versus host disease. So the question is, do we need it at all? And can we prevent graft versus host disease? I had talked previously about drugs being used to reduce graft versus host disease. And in this talk, I will talk about graft engineering. Now, we all know that any patient with, say, a hematological malignancy cannot be cured with just giving high-dose chemotherapy as a part of the conditioning. So this was a study done almost 30 years back where they looked at giving chemotherapy and transplantation of just CD34 positive cells. And if you look at the left side, right at the bottom, what you see is about 30% get cured with AML, 20% get cured with ALL. And if you look to the right side, you have almost a 20 to 50% chance of relapse. It just means that it is not just the CD34 cells alone that are needed, but you also need other cells in the graft which are useful for the graft versus leukemia or the graft versus host disease effect. And importantly, if you look at the table on the right, which looks at the causes of death that occurred in patients other than leukemia, one of the important causes was infection. So we know that there is a 30% relapse, there is a 40% transplant-related mortality. And this is data almost, actually, I would say almost 35 years back by Mary Horowitz, looking at leukemia relapse and then showing that there is a graft versus leukemia effect. And if you look at this, if you look at this table right on top, so if you have transplant involving twins, and like I said, in twins, they're completely identical, which means that the risk of GVH does not occur. You have almost a 60% chance of relapse of the disease. If you have a T depleted, that means you've taken out T cells by some method and then you transplant them, you have close to a 40% chance of relapse. And as you go down, when you get some amount of GVHD, you also have lower relapse rates. That means there's a graft versus host disease, but when the donor cells are reacting against the patient and causing GVHD, it also recognizes leukemia cells within the body, kills leukemia, and that is the graft versus leukemia effect. And the data suggests that if you had GVHD, you have lower relapse rates, you have better graft versus leukemia effect. So the question is, how can we manipulate both the conditioning and the cells to achieve GVL without wanting to have GVHD? So the things that you can do is, so for example, if you have transplant-related mortality, you want to reduce the mortality by using reduced toxicity conditioning. But the rest of it in terms of having the GVL effect and not having GVHD may be done using graft engineering. Sorry, the slides are not moving.
Yeah.
Yeah, okay. This is fine. So when we look at how we sort of manipulate the graft, the first thing that was done was what was called as CD34 enrichment. Oh, okay. Okay. So what did they do? Now we know that in the graft, there are CD34 positive cells, there are T cells, NK cells, a lot of cells. So what they did was they created an anti-CD34 antibody. And to the antibody, they actually mixed iron particles. So what you did was when you put that into the harvest, the CD34 cells would bind with the antibody, and to the antibody, they are laced with iron. So when you pass it through a magnetic separator, and this was an instrument called as the Clinipax, if you put on the magnet, then because the iron is bound to the CD34 anti-CD34 complex, all of it would get stuck. While the rest of the cells where the antibody does not bind will pass through. Then after that, once you release it, the ones which are bound will get collected into a different bag. So this way, you're able to purify and you're able to get almost 98 to 99% CD34 positive cells in a separate bag without anything else. Now you can do it as a positive selection, which means you get your CD34. You can also do a negative selection. That means you give CD3 antibodies and then you can separate out the T cells so that you have more. Now, when you did that, and this was the machine which initially I remember almost 25 years back, I went to Dr. Rupert's lab in St. Jude's to actually look at, because we were thinking of doing it in CMC, and there I spent almost 2 weeks with him learning about this. So what happened when we did CD34 enrichment? There was good engraftment. There were very low GVHD rates, but the problem was there was a high incidence of relapse. There's almost about 30% risk of relapse in AML, ALL, and so the overall event-free survival was only in the region of about 40%. And importantly, because there were no T cells, there was very poor immune constitution, and so a number of viral infections actually occurred in this group of patients. So initial results were good, but when they looked at long-term, the outcomes were not very different. So subsequently, they looked to see, okay, we don't do CD34 selection. Can we deplete the CD3 cells, which means you would still be able to keep the natural killer cells. Now, why is these natural killer cells important? Now, there is what is called as the killer immunoglobulin receptor, KIR, which is expressed on both donor and recipient. And these NK cells are very important looking at inhibitory and receptory antibodies and ligands. And if there is a KIR mismatch, that leads to reduced relapse. And if there is a match, that leads to reduced GVHD. So keeping the NK cells in the harvest made more sense. And there is some data to suggest that there is a longer graft versus leukemia effect when donor-derived stem cells were present and were thriving in the circulation. So this was a publication from St. Jude's. They looked at about 190 patients who are undergoing either sibling or unrelated donors based upon HLA and haploidentical donors based upon KIR. They did a CD3 depletion so that they could preserve the NK cells, and about 45% of them were MRD positive at the time of transplants. And this truly reflects a high-risk population of patients. And what they clearly showed was the outcome. So if you look at about 3 years post-transplant, and right on top are the blue curves with the haploidentical transplants, almost 80 to 85% survival, as compared to siblings, which were 70%, and unrelated, which were 60%. So this seemed to be useful, but unfortunately, there were still problems in terms of relapse. Now, when we look at T cells, we can broadly divide them into two groups, the alpha beta and the gamma delta. The alpha beta T cells, which have the alpha beta receptors, are the ones which are associated or cause graft versus host. The gamma delta T cells are the ones which are associated with tumor kill, viral infection being fought, and helping immune reconstitution. So then the question was, can you actually look and separate these out? Can you separate out the alpha beta because you don't want them? They cause graft versus host disease. You want the rest of it because that will help improve immune reconstitution as well as will cause the graft versus tumor effect. And that is where the whole process of TCR alpha beta depletion came in. That is the alpha beta T cell receptor alone, the T cells which carry those alone could be depleted. So what they did was, when you do a CD3 depletion, you will get your NK cells. When you do an alpha beta depletion, along with the NK cells, you'll also get your gamma delta T cells still there in the graft to be used for the patient. Now, the KIRs are again expressed on gamma delta, and because they're expressed on gamma delta, they help in both tumor kill. And so there was a study, multi-center T-cell alpha beta depletion study, where they took patients who needed a haploidentical transplant, who had a parental donor. They did do a reduced toxicity conditioning regimen so that there is a low transplant-related mortality, less effects of the conditioning. And they did a TCR alpha beta depleted graft, which preserved the NK cells and the gamma delta T cell. So this was done by the Pediatric Consortium in the US, 9 center. They took patients who were killed favorable, that means who had a KIR mismatch, and they used a combination of TLI, flu-thiotepa mel as conditioning, or a flu-bu-thiotepa. And what they also did was, they concurrently matched it with a set of patients from the CIBMTR to see whether the results that they're getting are similar or better than what happens in CIBMTR. And this was published in Blood about 3-4 years back. So if you look on the right graph, you look at the outcomes. So the right on top, which in red, are the haploidentical transplants, which was roughly about 75%. And below that in blue are the matched unrelated donor transplants, which are in the region of 60%, and the cord bloods, which are in the region of about 50%. So obviously, doing this transplant was helpful. This was early data, roughly about 3 to 4 years. But what they showed was that the results were even better than that of a sibling donor transplant. And they said that a haploidentical alpha beta depleted transplant using flu-mel-thiotepa may be the new standard benchmark for transplants. Now, there was still a problem. Although you did alpha beta, what was the problem was again still problems with immune reconstitution and infections. And so then the question was, can we give some memory cells back to the patient and take out just the ones which are likely to attack? And there came in the question in terms of whether you can do add-backs. Now, why are these memory cells important? These are important because they can important for control of cytomegalovirus. Now, you know that CMV is present in all of us. All of us have been exposed to it. In India, more than 98 or 99% are seropositive, which means that somewhere along the way you've got infection. Now, our immune system takes care and keeps the infection under control. But when you post-transplant, when you are severely immunosuppressed, or if the memory T cells do not come back, then there is the risk of CMV reactivation that occurs in this patient. And there is also some data to suggest that even in healthy patients, there are some of the antigens like WT1 or PR1, which are essentially tumor-associated antigens with acute myeloid leukemia, which may actually be present in low levels in these patients. So if there are these memory T cells present, actually infusion of these may actually aid in reducing the risk of relapse. Just go to the next slide, please. So when they looked at preclinical data, looking at the question of adding these memory T cells, what they found was that there was an early and robust memory to antigens such as HSV and CMV, and also against PHA, which meant that against infection and against tumor, they were likely to act. And the data from St. Jude suggested that if you did DLI, and that is the curve right on top in blue, you had a much lower risk of, you had better survival and lower risk of relapse, TRM and relapse as compared to if you did not do DLI. So over a period of time, graft engineering has improved. And with improvement in graft engineering, people are trying to see whether you can improve. So how do we do this graft engineering? So you get a PBSC harvest, and then sort of 90% of you alicot it into two. Right on top, about 90%, you keep it for the TCR alpha beta depletion, and about 10%, you keep it for the CD45RA depletion. From the 90%, which is the TCR alpha beta, you get your stem cells, you get your NK cells, you get your gamma delta T cells. You will also have your dendritic cells. You may or may not have B cells depending upon what kind of depletion you're doing. And from the rest of it, you have your memory cells and memory Tregs. So you use that first part for the transplant, and then you add these back on later. So there are some protocols which act on immediately and later. There are some protocols where they just add it on later. So this was a publication from the Singapore group looking at haploidentical transplants. They used a combination of thiotepa, fludarabine, melphalan, and TLI, and they did a TCR alpha beta depleted transplant and a CD45 RA depleted DLI. So they had about 107 patients. This is more adults. Median age is 52. Engraftment was okay. 12 days, you get your absolute neutrophil count up. 11 days, you get your platelet count up. There was only one patient with primary graft failure, and you look down below, acute GVHD rates of 26% with only about 9% of grade 3 to grade 4. They had 17% relapse rates and one infection due to adenoviral disease. And when they looked at the overall survival, it's roughly about 63%. And what they did was they compared it against the BMT CTN 1101 trial, which looked at cord blood versus haploidentical transplants. And essentially, the rates of survival were similar between both groups. They also compared their own data with the in-house PTCY, post-transplant cyclophosphamide, which was a standard they were using. And on the left, if you look, the haplo TCD had a graph GVHD-free, relapse-free survival of about 50%, as compared to about 30% when you use the haploidentical protocol with PTCY. And when they looked at a propensity matched analysis, it still held good 50% versus 30%. So using this kind of graft engineering would definitely help in improving outcomes with haploidentical transplants, even above PTCY. So this was their overall data when they looked at with in-house, and they also looked at, they also looked at compared with the in-house data which they had from Singapore. So they looked at the haploidentical TCD versus the match-related versus the matched unrelated and the mismatch. And if you look at the left side, the haplo TCD actually had very good results with an overall survival of about 70%, event-free survival about 60%, while it was similar to the matched unrelated, better than the matched unrelated, similar to the matched related donors. And importantly, if you look at the GVHD rates, they are actually very, very low. So what has happened over a period of time is that with graft engineering and increased manipulation of the graft, you are able to get better T cell depletion. At the same time, we are able to give back the cells that are necessary for the body in terms of immune reconstitution and in reconstitution against viruses. So we have moved from CD34 enrichment to CD3, CD19 depletion to TCR alpha beta, CD19 depletion to TCR alpha beta, CD45RA depletion. And with that, what we are seeing is in terms of the cells, the amount of cells that we actually need, stem cells, NK cells, the gamma delta T cells, the memory cells are all going back into the body and helping in improvement. So overall, it seems to suggest that with improvement, with all these strategies, we are able to improve the outcomes of haploidentical transplants. We have better GVL effect, reduced GVHD, and we have very good data in haploidentical transplants, which are superior to many of the other schemes. Now, importantly, we don't stop there. There is actually a lot of other things that you can do with the graft. So people are looking, and these are all in different phases of clinical trials. Hopefully, will come into the clinic, but people are looking to see whether we can just get T cell gamma delta. You can get CAR T cells, you can get CAR T regulatory cells, and there are a lot of things where you can take T cells, add in suicide genes, so that once the T cell work is over, you can actually kill them. So there are multiple ways by which these cells, once you take them out, can be manipulated and then put back into the patient to help make the transplant more successful. So I'll just briefly, 2 minutes, talk about our program. So we started the transplant program in 1986, and we have completed about 3,300 allogenic transplants and about 1,800 autologous transplants, mainly matched siblings. We've done about 500 haplos and 200 MUDs. As you look below, because we have a large burden with thalassemia, that is our biggest group of transplants, followed by acute myeloid leukemia. And the third, of course, because we have a lot of burden with aplastic anemia, our third highest group is aplastic anemia. We do about 200 allogenic and 120 autologous. 40% of our transplants are in children with 1 to 2 MUD transplants. And when we look at haploidentical transplants, the biggest group is leukemia. So 31% AML and 19% ALL, followed by bone marrow failure. But there is a huge amount of diseases that we do. Primary immunodeficiency disorders, glycogen storage disorders, diseases like Fanconi anemia, Diamond-Blackfan anemia, hemoglobinopathies that we are also doing. So this is our alpha-beta depleted protocol. We give fludarabine with either melphalan. We have been focusing mainly on trying to expand this out, this one for older patients with AML and MDS to see, because earlier we were finding it difficult to take anyone beyond 55, 60 for a transplant. because the outcomes with the PTCY was very poor. So we developed this protocol actually to see whether we can expand the age. So we do this, we give either melphalan or trio, we give 1 dose of rituximab because it's B-cell depleted also. And then we do a alpha beta depleted transplant looking at 10 to 15 CD34s with a low alpha beta. We do not use any post-transplant immunosuppression unless the alpha beta dose is very high. And then we give memory add backs at day 30, day 60, day 90 in escalated doses. And like I had mentioned earlier, we actually give 90% for the alpha beta and the rest for the add back. And so this is, I will just, so I'll just go forward. So this is the kind of doses that we get. So if you look, these are different patients. So we give between 10 to 15 CD34s. And if you look on the right side, most of them, we are able to get very good TCR alpha beta depletion. So the amount of alpha beta depletion that we give is very low. So we have done about 20 transplants in the last 2 years, median age of 55. We recently did one kid, 3-year-old child also, but most of it has been adults, AML, MDS, and MPAL. And we median CD34 dose of 13, alpha beta dose ranging from 0 to 0.9. We had 2 graft failures, median age to so the median time to transplant is 10 days, which is far earlier than when we do PTCY, which is between 17 to 20 days. The median time to platelet engraftment is 16. We had SOS in 1 patient, acute GVHD rates of 26%. The CMV reactivation rates are still high in our group. And now we have added on Letamover because it's now available, generic is available in our country. And importantly, right at the bottom, about 70% are alive and well, which I am sure we would not have achieved if we had subjected these patients to actually going through a PTCY haploidentical transplant. With this, I'll stop and I will hand it over to Dr. Rupert.
Yes, thank you, Prof. Biju. In this topic, we learned that sometimes manipulation legal, yeah, and how we manipulate T cell from enrich CD34 by positive selectivity and negative selectivity, and then increase NK cell, increase also gamma delta T cell, and also add back memory T cell. Yeah. But keep patient and then hold your question because more interesting topic will come. Bridging the gap, integrating cell therapy into pediatric BMT program by Prof. Rupert.
Thank
Please.
you. Can you hear? Yeah. So now we have already heard how important maybe cell therapy can be, and also how important in a transplant center or in a cell therapy center it is important to have such a facility, which you, I think, you are building here at Darmais, hopefully, or it's already in and I can show you a little bit what Dr. Biju has already showed you, what can be done in the transplant setting. But it's not only the transplant, it's also cell therapy, where this manipulation of cells as a biological drug is getting more and more important. And cell therapy has become a long way, as you can see here. Tumor-infiltrated lymphocytes to treat metastatic cancer has been started in the late 80s already to try. And then over time, of course, you all have heard of CAR T cells and all the developments of CAR T cells. And that led also, I think it was in 2000, and read it in 11 or so, was the breakthrough of the year was cancer immunotherapy T cells on the attack. I think this is when the checkpoint inhibitors came out. So what are CAR T cells? I think this is the new hit on the block, CAR T cells, and this is a mixture of the monoclonal antibody, where you take the antigen recognizing part of the monoclonal antibody, and you put it together with a part of the T cell receptor, with the T cell receptor which signals intracellular into the T cells. This is done genetically done, And at the end, you have a T cell which recognizes the specificity of the antibody. This is why it's called chimeric. It's a mixture of a T and a B cell. This has been described already many years ago by Dr. Eshar in Israel in 1990s, but then I think it was forgotten for around 20 years. It was not seen how important this could be, but now it has received wide attention worldwide and is now really something very interesting. This is how you do it. This is more the technical aspect. You put the DNA coding for this receptor, for this fusion into a cell line. Then the cell line produces these virus particles. We use lentiviral particles carrying the information. Then you transduce these T cells with these lentiviral particles, and then the DNA is incorporated into the T cell DNA. And at the end, the T cells expresses this chimeric receptor, which recognizes, in this case, B cell lymphoma, because we use the CD19 antibody. So the target specificity of antibody recognizing CD19. That was the first patient treated worldwide forever in 2012 in the Children's Hospital in Philadelphia. Emily, she's widely known. In the meantime, of course, he had a very refractory acute lymphoblastic leukemia, refractory to everything at that time, what was available. And she then got these T cells, these CAR T cells for the first time. And she responded dramatically. Of course, she got also very sick with it, but I show you this in a second. Since she responded dramatically, is now what I heard last is a medical student at the same institute where she was treated. And that caused a lot of attention in the community and also led to the study, to the Eliana study, using these CAR T cells in children and young adults with chemorefractory B lymphoblastic leukemia, published in 2014, also by the Philadelphia group. And you can see here the event-free survival was 50% and the overall survival better. And of course, these were all patients who would not have had another chance to get any treatment because they were completely refractory on all substances which were available at that time. So very successful. And that was then the multi-center study, the Eliana study, in 75 patients, very similar results as before observed, the event and overall survival. And this led to the approval of this T-again Leclucel, which is called Kymriah. Maybe this is by the Novartis company now distributed as a drug. Unfortunately, it's very expensive. I think it's at a range of 400 or 500,000 US dollar. So not affordable for most countries, to be honest. Even for rich countries, it's a problem to get these approvals from the insurances for these very expensive drugs, but very effective, as you can see here. But there were also side effects, and Emily was the first who showed these side effects, because there is, with the infusion of these CAR T cells, once they recognize their target, they start to do their work. They are activated. And activated T cells produce a lot of cytokines like interleukin-6, interleukin-8, interleukin whatever. And that causes what we call the cytokine release syndrome in these patients, which is quite severe if you don't treat it. And Emily ended up on the ICU. She was on the ventilator and she was almost to die, what I hear from the investigators at that time. And then some investigators, let's try something. And they gave her the IL-6 antagonist, tocilizumab, and that saved her life. So this is now also something, this is shown here, the tocilizumab. You can treat or also prevent this cytokine release syndrome very effectively nowadays. Sometimes patients need additional steroids. There are other side effects associated, some neurological side effects, but most important, if the CAR T cells persist, these patients are T-cell lymphopenic because it's a CD19 antigen they recognize. So if you have persistent CAR T cell, patients have no big cells, but advantage is they also don't get the relapse. So you have to, the two sides, you can keep the leukemia under control, but you have no B cells because CD19 is also on normal B cells expressed. It's not a tumor-specific or leukemia-specific antigen. And this is what we aim, of course, persistence of CAR T cells to avoid relapse. So when do we use these CAR T cells? And this is also the big question, and this is in pediatrics. We have the primary disease, very high-risk patient get a transplant, maybe upfront if they relapse. This is approved now for CAR T cells. Here we have the first relapse, the patient get a transplant in the first relapse, and then they relapse again, CAR T cells. But you see, we already are CAR T cells very late in the treatment. And we still hope that these patients will still get a chance. So this is something we are always discussing. Is it a bridging to transplant? Do we have to bring the patient into remission here before we go into a transplant to make them MRD negative? So what is where is the best time point to use CAR T cells? And I'll discuss this with you a little bit later. There is no final answer to this question. This is the discussion in every conference. CAR T cells, how to use it. One is even, can we replace transplant here or here with CAR T cells? And not CAR T and not with transplant at all. I think this is also something which needs to be discussed. These are the approved products now. As I told you, the very expensive one, as you can see here, the Kymriah is approved for children with acute lymphoblastic leukemia, because this is also the different things. Normally, this therapy was first used in children. Normally, new therapies, the regulators only allow it to use first in adults and then go to children. Here it was the other way around. It was first done in children and then moved to the adults. So it also can be done also successfully. And this is the real-world data. Of course, this was a study before, but real-world data, when not on defined studies, might look a little bit different. And you can see here that we have still relapses in these patients after Kymriah, still after the CAR T cells. And it has been shown that these CAR T, these relapses are CD19 negative. So some of them, there is a escape phenomena that these B-cell lymphoblastic cells, they only get rid of their CD19 antigen, then the CAR T cells are blind and cannot recognize these blasts anymore. And this has been seen more and more, depending on the center. These CD19 negative relapses after CD19 CARs are a problem. And of course, the real-world data maybe are impressive, positive as in the study, but study patients always do better than real-world data, not on a study. This is the mechanism of CD19 negative relapse. There are various investigations why they get this. I think it's epitope masking, B lineage change, or just get rid of the CD19 mutations in the expression, and then the CAR T cells are blind. So one approach, and this is the approach we use also now, is to use a tandem CAR. We use two target structures in the same vector, recognizing CD19 and CD22. CD22 is also a good marker for leukemia in children. And this is how these CARs are produced, and this is why the company says it's so expensive, because you have to get the lymphocytes from the donor with the apherases, then they do a T-cell stimulation, they transduce this with this lentiviral vector, then they do the expansion, then the cells are frozen, they are shipped frozen back to the facility and then infused into the patient. So the question is, can we do this ourselves on site? And the answer is yes, we can do this because the company which sponsors us today has devised, here is the name, a nice method, using this Clinimax Prodigy, where you can do the same steps all automatically in a short time. And this is what we're doing. We take the cells from the patient, we put it on the machine here, and then it takes, according to your protocol, 6 to 12 days. And it's almost automatically that you get then the CAR T cells out here and you infuse it freshly to the patient. This is also important, what we call vein-to-vein time. If you do it with the company, you might have up to 4 to 6 or 8 or even longer weeks waiting time until you get a cell back. If you have a chemorefractory leukemia with daily increasing counts, you don't have 4 weeks time to treat this patient, or aggressive lymphomas. in the adult setting, sometimes you don't have 4 weeks time or 8 weeks time to get the cells back. This is the biggest advantage, is the time, vein to vein time, and this has been shown is very important also for the outcome. So we have used the CD1922 CARs in Tübingen as a pilot study, comprising children and also some adults, where we produce these cells on site in our hospital. 6 patients had their own CARs. 3, we call it pseudo-allogeneic, because this is a patient who relapsed after transplant. He has the donor, still the donor hematopoiesis, but we use the CARs from him. That's why we call it pseudo-allogeneic. And one patient had it allogeneic from the donor itself. I will discuss this patient in a second. And this was our outcome, was very good. We had 6 of these 9 patients had a complete remission, I think, which was also for us very surprising to have this good response. These are the patients who relapsed after transplant. This patient relapsed after 2 transplants, which is normally a bad thing to have, and still responded to the CAR T cells. And this patient was also very refractory down here. The 17-year-old girl was very refractory to therapy. She got a transplant while not in. We normally don't do, but we generated CARs from the donor, not from her, from the donor, because we anticipated a progression after transplant. And then this is the story of the patient shortly. She had a lot of disease, severe toxicity. Then she got autologous CARs first. We tried twice, but she did not respond to that. Then she got again, just to keep her a little bit on bay with her leukemia. And then we did a transplant with the alpha-beta depleted graft, as Dr. Bishu showed you already, while not in remission and no immunosuppression, but she still had a lot of macroscopic disease and even progression. And then we gave her the donor CARs, which we produced already when we got a stem cell graft and froze them. And then we gave her these cells. And she had a very nice expansion of these donor CAR T cells, as you can see here. Both of the CD1922. She only had a mild skin grade 1 GVH because we infused donor T cells. This is also very interesting. We infuse large number of donor T cells and do not get a lot of graft versus host disease. We don't know yet why this is, because the cells are already so exhausted or activated, or these alloreactive T cells have been grown out in the CAR manufacturing process. But this has been now observed also by other groups, that donor CAR T cells are not associated with a lot of graft versus host disease. This is her disease, as you can see here. This is the bone marrow was also full. This is the PET MRT. This was lymphomas all over. 4 weeks after transplant, then 8 weeks after transplant progression. Then we gave her the CAR T cells, and 4 weeks after the donor CAR T cells, she was in complete remission. And this is now even 1 year old. She's also now more than 4 years in complete remission. And I saw her last year. She came from Saudi Arabia. I was in Riyadh. Unfortunately, we could check whether she still has CAR T cells. I told you the distance is very important to keep them in remission. And this is the CAR T cell. She has still 25% of the donor CAR T cells 3 years after the infusion. So I think, and there is now, I think, more and more tendency to go, especially if you have a relapse after transplant, to go to donor CAR T cells. This is important because in haplo setting, the donor is still there. This is what Dr. Bishu mentioned. The donor is available day and night, sitting at the bedside. You don't have to search the donor. Maybe you have to bring him from the cafeteria, but he's in the hospital 24/7, at least in the pediatric floor. We have the parents around 24/7 often. So the donor is there and you can do this. This is the big advantage. That leaves us, if we get more experience with CAR T cells and we get more control over the side effects, which we get more experience, the question is again, where do we put them? My future perspective, I mean, now I'm retired, to be honest, so I don't know what's going on in the next 10 or 20 years, but I would foresee that we completely avoid transplantation and replace it with CAR T cells and only give a transplant if they fail CAR T cells, because then we have a much less toxic therapy, and we have a biological drug. Once the drug is in, it stays in. If you are lucky, 3 or 4 years, the patient stays in remission. You don't need to give maintenance therapy or long therapy if they stay, and it's easy to check whether they stay. So you can follow this patient very closely, and then you can still, if you lose that, or the B cell marker is very easy to do. This is a biological marker for your persistence. If they have no B cells in the blood, still there and working, if you see B cells, you have a problem. You better look in the bone marrow whether the patient relapses. But this is something we need to discuss also in pediatrics, whether we can get rid of TBI long-term effects, side effects. We get a lot of secondary cancer. Now the risk goes up. In our old study in Germany, where we give 12-grade TBI for conditioning, we have already a risk of 15% of secondary malignancies after now 20 years, and there is no yet a plateau. It still goes up. So we have to be careful also what we do when the children are still young, whether we really do the best to bring them into remission at that time and forget what happens to them in 20 years. So we need to be, I think, a little bit smarter. The other thing is where cell therapy can be of very important is thalassemia, and I think you know better thalassemia than I do. You have a lot of it in your area of the world. This is where I'm currently. We also have it here. I'm currently also a consultant here in Abu Dhabi, in the Emirates, but there's a lot here, and you know all the Cooley anemia, what it's called in the US, and this is also something Dr. Bishu has mentioned. You can cure it by allogeneic transplantation, but then you also have the risk of mortality, morbidity. If you have a patient with a non-malignant disease, like I showed you, and has a chronic graft-versus-host disease and has scleroderma, and you have cured the thalassemia, but have you really helped the patient? That's the question. So there is also the question, can we do differently to cure thalassemia? And of course, there comes the gene therapy in. There are two approaches with the gene therapy. One is to give the gene of the thalassemia via a vector, like we do it with the cells. We make a vector with the beta gene, and then we transduce this into the CD34 cells, and then the CD4 cells replace the patient's hematopoiesis and produce beta globin. This is working. This has been shown here in this paper, and this is approved under the name of Zynteglo. But the problem again is the price, $2.8 million for one patient. Almost no, even rich countries cannot afford this. And it's ridiculous, because this is very few patients who would profit from this. The other approach we have used is the gene therapy, a non-lentiviral approach, where we disrupt or we knock out BCL11A with a guide RNA and the Cas9 by electroporation into CD34 cells also. And this disruption of the BCL11A leads to a resurface of gamma globin. Because we know that in the fetal period, in the post-conceptual dose, our hemoglobin is mainly gamma, alpha and gamma globin, and then we do almost have no gamma globin and beta globin. If we disrupt A after birth, gamma globin starts again to rise, and then the patients have a high level of gamma globin and they can live with it, both of them, without transfusions. And this has been shown also in this trial with beta 0 and beta 0 beta plus. Thalassemia, I was also part of the study. And in our hospital, in my hospital, we did 8 patients with thalassemia using this approach with the CRISPR gene therapy. And this is also approved under the name of Casgevy, but also in the price range of, I think, $2.3 million. So also not to most countries, even in Germany, we have problems to get insurance for this, paying this. So what we do, of course, we try to ask, can we do it ourselves on site with the cheapest way as we do CAR T cells? Can we do it? And this is the approach. We isolate the CD34 cells, as Dr. Bischoff has shown already. Then we have an electroporator where we electroporate this guide RNA and this Cas9, which is important for the CRISPR therapy, into the CD34 cells. We do quality control, we freeze the cells, then we prepare the patient and we can do it. And we can use the same machine as we use for generation of T cells. And of course, just to let you know, this machine can do more. This machine can do alpha beta depletion, can do CD45 RA depletion, can do CD4 selection, can do everything. And some more at the end, electroporator, which electroporates this guide RNA and the Cas9 into the CD34 cells. You can see it's a closed system, and we have just recently published, it's now published that we can do it. We can do it on site, GMP grade. Doing this, of course, the companies are not very happy that we try this, of course, but I think we have to continue to make this approach more usable also for others. And you can see we get a nice hemoglobin, fetal hemoglobin production in the CD34 stem cells. The other problem in transplant is, Dr. Bischoff has mentioned, is viral infections, and they can be lethal. CMV, adenovirus, Epstein-Barr, or now even sometimes BK virus creates a problem. But the biggest problem in children is often adenovirus, which is very difficult to treat, not so much CMV, but adenovirus. And we have also published methods how we can use cell therapy to treat viral infections when they are chemorefractory. And this is also where we do the same approach. We use from the donor or from a third-party donor who has in his repertoire, for example, adenovirus-specific T cells, and stimulate them overnight with peptides against this adenovirus panel. And then we isolate the reactive T cells overnight. This is still the prodigy, but we can, at the Clinimax, we can also do the prodigy, which does it automatically. Then we have these T cells, we give it to the patient. And fortunately, when these T cells see the antigen in the patient, they expand. So sometimes we only give maybe 1,000 or 2,000 T cells of this virus-specific antigens into a patient, and the response is quite very dramatic in some of the patients. As you can see here, these are CMV-specific T cell responses, and you can see the copy number, how the copy number responds after infusion of these CMV-specific cells. And of course, you can imagine this patient had all drugs to treat CMV at this point when we come to the cell therapy. So these are all chemo-refractory CMV infections, and we have good outcome of these patients. The same for adenovirus. In children, this is not so much in adult, but in children, as you can see, the mortality rate can be quite high. You have an adenovirus infection after transplantation, and this happens mainly in very immune patients, especially if you have GVH and a lot of immunosuppressive therapy. It's almost sure that your patient will have problems with CMV reactivation, but also in children with adenovirus, and then it's often chemorefractory. There are no really good drugs there to treat adenovirus infection. So we also give this adenovirus-specific T cells, and again, we can reduce the viremia when the T cells, which we infuse, when they expand. This is the blue one. Then we get also the viral clearance in almost 80% of the time. We still can get viral control giving these T cells from the donor. If the donor, we checked before whether the donor has them in the repertoire. We also use third-party donors because they don't have to persist like in CAR T cells. They only have to be transiently active until the patient is able to recover himself, his immune reaction against the virus. This is the mortality in the patient with adenovirus. As you can see here, In the non-responders, the mortality the same. These patients will die from adenovirus infection. If we use the T cells, we still have around 70% responders and also and survivors, of course. So this is something which we have to keep in mind. And if you have such a cell factory on place, I think you can do a lot, not only generating alpha beta or CAR T cells. So it's very versatile, these approaches. And that's I think, a big advantage in the modern cell therapy. And the same for Epstein-Barr virus. Sometimes we have Epstein-Barr virus problems or EBV associated lymphomas post-transplant. And then we have also a problem. We have this post-transplant lymphoproliferation, the PTLD, which is also refractory EBV infection. And also we try to give EBV-specific T cells. And you see the number of EBV-specific T cells, this is only 5,000 this per kilogram. So this is one drop of cells. But they still, in vivo, if they recognize genders, they, like the CAR T cells do, when they see the antigen, when they see the leukemic cells, they start to expand. And the virus-specific T cells do the same. And this leads to the clinical response of this EBV PTLD. This is, for example, here in the liver. You see these PTLD lymphomas here. And this is all disappearing. And you see here the copy number going down. So I think it's very important to establish this kind of facilities, which you are in the process now, to have these things later also available in the future. And maybe more and more new development is coming. And for this, I thank you for your attention. And I think now we have the discussions.
Thank you, Prof. Rupert. You may have to take a seat, and then we have already heard about the 4 topics about the graft engineering, and then I open the discussion from the floor, online and offline. Maybe the first, I would like to invite the offline audience to have some comment maybe or some questions. Is there any question from the offline audience? If not, I'd like to see the online meeting, and then there is one question, Prof. Good afternoon. Thank you for both of speakers for a guest presentation today. My name is Dihayu from Darmais Hospital. I want to ask you about GVHD. How to distinguish the redness on the palm of the hands or foot? Is that GVHD or there is side effect of chemotherapy conditioning or hand-foot syndrome? Maybe for...
Yeah, of course, this is sometimes very difficult to see whether it's still maybe from the conditioning, you might have redness. But if you are suspecting GVHD, it's only redness on the palms. Maybe some local treatment is fine, some steroid cream or something is fine. So not every patient needs steroids. If you are not sure, then you can do a biopsy if it's more on the skin. But like I showed you, this only redness on the palms. Maybe we would only first, because the patient will be already on tacrolimus or cyclosporine prophylaxis, then maybe a local therapy is good enough. But if it's getting more and more, then I think it's not toxicity. Of course, we have skin toxicity. We have from fludarabine, you can have skin toxicity. TBI sometimes can make this, but not so late, maybe when GVH is coming. That's all you have to put into account. if it's more skin is involved, but it's typical. The edge is very typical. You know, at the edge of the palm and at the feet. It's a very typical picture. I haven't seen skin toxicity so clearly as GVH, you know, so different at the location. We don't know why it's so on the palms or on the feet, but it's very typical. I think it can be recognized if we are not sure and use local treatment of steroids that's not immunosuppressive, and it will go away. Some of the pain gets more, you have to start steroids.
Yeah, I would also add on saying that generally the toxicity, we see that in a few patients because we use a lot of triosulfan, but that occurs very early. So generally for graft versus host disease to occur, it occurs post-engraftment. So generally it's beyond day 14 to 21. Like Dr. Rupert said, sometimes you don't even need to treat. We follow the rule of nines, and which means that you look at the extent of the body surface involvement before you decide whether you need any systemic treatment. Any of the times with just local therapy, it's enough. And I think most important, you should have a good dermatology colleague who's experienced in transplant dermatology. It's very useful.
Prof, in the condition that we are hesitate to differentiate between this condition, which ones we prefer? GVHD?
See, I mean, what are you going to do if it's localized therapy? You're going to give localized steroid creams. That will help for both. So it does not matter. What matters is able to distinguish it once you decide you need systemic therapy. There, like Dr. Rupert said, doing skin biopsy is useful in terms of trying to distinguish, because you see a lot of lymphocytic infiltration when it's graft versus host.
Okay, thank you. Any question from the floor? Prof. Viju, regarding the effect, GVL effect of NKT cell and also here, but maybe the GVL effect can be too strong and then make persistent cytopenia. How can we balance it?
So I mean, I don't think there is an exact science in terms of saying if you give so many cells, you will get one effect without the other. So sometimes what happens is, yes, you can get a persistent cytopenia that occurs, but many of the times, as long as you're clear in terms of marrow that it's not a relapse of the disease and that your chimerism is complete, many times the cytopenia, you can just wait it out and it will slowly over a period of time improve. The problem occurs if your cytopenia becomes very bad, your absolute neutrophil count is less than 500, or your platelets have dropped, then it's a worry. But otherwise, many of the times, the mild cytopenias, you can just wait it out. It will improve over a period of time.
Okay. To Prof. Rupert maybe. I it's really interested in your idea in upfront CAR-T. But maybe for GVHD and for GVHD topic, how about upfront ruxolitinib to replace steroid? Because we consider CMV infection, which is disadvantage of steroid.
That's now more and more coming, that people using it also more upfront. I think when you have GVHD, you would first do a few days steroids. I think that's still the standard. But what you should not do if you see this is still maybe done too much. If you don't see it works, you also be courageous enough to stop it. But most people don't dare to stop it. Right? This is where you create a problem. If you see steroid refractory, there is no need to further give it. You only cause problems. Then maybe this is then ruxolitinib and other things come in. But because I know that sometimes people even give more steroids, they double the dose or go to 10, and then you cause all the problems coming with it. So this is also something we have learned. I think that if steroids not working, don't use them to the extent.
I mean, unfortunately, one of the problems in current practice that we have is we still do not have enough good biomarkers that are available immediately when you have a patient with GVHD to predict who's likely to develop steroid refractory and who's likely to be steroid sensitive. You look at most of the biomarker data, it is in retrospective. That is beyond after you've treated. Since we do not have that, a lot of people, earlier ruxolitinib was sort of like third line, then became second line because of the READ studies. Now people are looking to see whether we can push it up further so that we can prevent steroid refractory. But I think like Dr. Rupert mentioned, one of the things which people forget is the fact that once you've decided to put on ruxolitinib, you cut the steroid dose. If you do not do that, you're inviting CMV, you're inviting fungus, a lot of host of other things that follow.
Okay, thank you. Any good?
I have a question for Dr.
Oh, yes, sure.
So now with the alpha beta depletion and you compare post-strike in haploidentical transplantation, of course, the argument is always the price. That this technology, alpha beta depletion, is so expensive or cost more. But if you see the whole first, let's say, of a 1 year treatment, you use no immunosuppression with ex vivo depletion. Maybe you have less hemorrhagic cystitis. I don't know. You have some problem. The patient in graft faster. Do you think there's a big difference in the hope of those methods? If you put together.
So one of the things we learned with the haplo PTCY is that in the first year after the PTCY, expect at least 3 to 4 admissions or repeated infection. That is what happens when you give post-transplant cyclophosphamide. Definitely, that seems to be lower. The engraftment, very importantly, is much faster. So it's at least about 5 to 7 days faster when you're doing an alpha beta depleted transplant as compared to if you're doing a PTCY. Long term, I think it will even out. But for us, we need to study much larger numbers for us to say. But I think in the initial experience that we have, it is definitely a tool I would definitely recommend to patients, provided the finances are there.
For ex vivo T-cell manipulation by clinical prodigy, do we need to have GMP facility?
Type 607 fine, because the machine is not open. You can do it. And now we have a program also which does alpha beta depletion in 45 array in the same machine, in the same run. So it's getting also more sophisticated a little bit, and more programs coming. We have now also a program that has not been mentioned here in the future, that we can, after alpha beta depletion, can find this in gamma delta in the machine, then donor lymphocyte infusion later. First, what the visual has shown, these gamma delta cells are also undetected T cells. And the most important is, and here showed that gamma delta T cells, also there is particular CD3 positive T cells that do not cause graft. They are not tolerant. So you can give a lot of them. Otherwise, we could not do alpha beta. Then you can give a lot of them without GVH risk, and this is what we are also now working to expand these cells also in the machine and later.
After engineering, I think we've been learning lessons along the way. So when we started with doing the Clinimax and the CD34, we thought that's it. But we realized there's relapses, there is infection. That is how we've been trying to see. I think one of the important things is that we learned a lot about the biology of each of the cells that are there in the graft, what they do. And that has helped us in saying, what do we need from the graft and what are the things which we can exclude. That is how I think things are moving forward. Like what Dr. Rupert said now, if you can get NK cells and then you can expand them so that by 1 month you can give in more cells, reduce relapse, improve immune reconstitution, that will become better in terms of long-term outcomes.
Okay, Prof. Prof. Rupert, a bit about CAR-T. Tocilizumab can prevent or treat CRS. and usually ICANS happen after TRS, but tocilizumab cannot prevent ICANS. How can we explain that?
I mean, the tocilizumab is very effective in treating the CRS, and also now people give it also more upfront prevention without having the risk that the task is less effective. ICANS, I think, still occur later in the course, as I showed you. And you need maybe other drugs for ICANS. Of course, then dexamethasone is important for ICANS. So maybe tocilizumab is not maybe going to the blood-brain barrier to go to where the ICANS are affected, because we see the CAR T cells in the brain or in the cerebrospinal fluid. There are CAR T cells. This is a biological drug which crosses the blood-brain barrier. And this is also why we have good results when we have, for example, a CNS, a refractory CNS disease with leukemia. CAR T cells is it. This is better than total body irradiation or final irradiation with all the following problems. So the CAR T cells can cure CNS involvement. We have also seen, for example, testis is also a problem in boys, that they have testis leukemia. It's also curable in testis without removing it or without irradiation. This has already been done. So it's a biological drug which goes where this is completely different from what we are used in chemotherapy or something. The biological drugs which looks it started in the body. Chemotherapy cannot do this, cannot decide between normal cell and cancer cell. It will kill both. These cells, they can kill the healthy B cells, but they won't affect the liver cell or other cells. Go where leukemia is. And this is, I think, the big advantage. This is why I really think that in pediatrics, we have to do all efforts to replace transplant in the future. This 12 total body irradiation, we see so many side effects. 70% of the long-term side effects after allotransplant is from TBI alone. From TBI, growth, hormonal dysregulation, the decreased growth of the children, and secondary cancer, this is of concern. I think we need to do all efforts to avoid this. In adults, it might be. But in children, I think we have a special responsibility to have new thinking, at least, whether we can do better.
Maybe also in infant ILL, something like that.
I mean, we don't do TBI in children below 4 years of age, but some centers do. I have to say, some centers are less of concern. I wouldn't do it. In the US, when I was there, I've also seen partially infants getting TBI. I wouldn't do that.
So with the generation of cars that have come up, I think the incidence of both the CRS and ICANS has come down because the cars have by general become much better. So unlike what you see from the initial data where there's 40, 50, 60% CRS, which were grade 3 to 4. Now most of them are grade 1 to 2, which means that you could just wait and watch, give symptomatic treatment, and most of them will actually settle down.
This is a good point, because what we have learned is in the original studies, these patients were all ignorant. They had a lot of, it has been shown the number of blood most important for the kidney or for the urine of the CRS. You have a lot of blood, then the CRS probability is quite high. Now we try to keep this up in the children that below 5% of blood, when you CRS, or even in the blood. Here, to use that as a criteria. This is why I think we could in very high risk patients. Like here, you don't have an alternative transplant, or you don't have transplant activities, or you don't want to come into upload new sensor, I don't have to. And let's say in pediatrics, yeah, I know in shop, I know the people are very well, they don't do automatically transplant. They watch them very exactly. How can we do that method for MIT? Right.
So we have Dr. Liana here as our pathologist. Sorry. uh, Based on the lectures of Prof. Biju, Prof. Biju, do we need or is it obligation to have typing and
No.
HLA typing?
HLA typing, definitely yes. And yes, ideally, if you can do KIR typing, that would help in that. Because remember, when we are looking at a haploidentical transplant, you have the opportunity of having multiple donors. So when you have multiple donors, it would be best to get a donor where you think that the chances of curing the disease becomes better. So definitely KIR typing would be useful. A lot of places would automatically get KIR done along with the HLA if it is possible, and then use that to decide on the dose.
Okay. Any question from the floor? Liana? Continuing when we want to starting the clinical trial for CAR-T, Prof. Rupert, and then there is many patient of us have the history of CNS2, CNS3, something like that, but CNS2, or CNS3. But at the time being, it is already CNS1. Do you think it's safety to give the CAR-T for the kind of patient?
Of course. There's no problem. Yeah, no, of course. This is exactly maybe what brings the patient into better remission. Is that because it's a biological drug, they go there. You know, you have to go intrathecally with your drug. These cells, they go there when you inject them with blood. They cross the blood-brain barrier. And
people were worried if somebody had active CNS disease and you were giving CAR-T, would you actually reach the CNS? Because in a transplant, you give TBI. But there is enough data, like Dr. Rupert said, to show that when you have an inflamed blood-brain barrier, definitely the CAR-T cells will go there and will have an effect on the cells which are there inside the brain. So having CNS disease does not mean you cannot give CAR-T cells. You can definitely give it.
Okay. Prof. Biju, I was wondering about the when you choose the horse ATG and rabbit ATG.
So the horse ATG we have generally used it in patients where you want to immunosuppress the patient, but not much for its GVHD effect. So for example, when we are doing unrelated donor transplants for thalassemia or haplos for thal, haplos for aplastic, where because especially those who are multiply transfused, we would prefer to use OS ATG, and we use it very early. If we want it more for its GVHD effect, we use rabbit ATG and we use it late. That means very closer to the graft. That is what we commonly do when we are doing a matched, unrelated donor transplant for ALL or AML. We don't want too much of GVH, so we give it.
Okay. If there is no question again from the floor, maybe for the last times, I would like to ask suggestion from both speakers how your trick and trips to our resource limited setting in our country in developing bone marrow transplantation and also cell therapy.
I'll start. Okay. So I would say that we were in the situation that you were in the 1980s when we started transplants. We did, in the initial 5 years, we did one transplant per year because it was not even heard of in India. So that is how we started up. Then as standard transplant became successful, people. So I would say what you have to do in Indonesia is to look at what are the diseases that are most common and concentrate on them, because that is where you would get the maximum benefit for the population. So whichever disease, whether it's malignancies, hemoglobinopathies, whatever it is, those are the things you should start off. And it's very important to establish a unit. So for example, at our center, it's not just me. There are 8 of us consultants. There are residents. Most important, there is a huge amount of nurses who are well trained in transplant. So you have to develop a team. If you do not develop a team, it is very difficult to have a successful transplant program. Once you get that going, then things add on. Whether you want to do alpha beta depleted, whether you want to look at CAR, you may decide, okay, it's difficult to get resources for transplant, but I can do CAR. That is also an option people can look. But I think it's very important to put a focus on the diseases that are most common in Indonesia, in children, and say that is where I would start off with and go forward.
I think the most easier transplants, maybe in what other centers are now also doing in other countries in the area, is the med sibling transplant in thalassemia, because there the complications, you can have complications, but they are lower than you have leukemic patients with second relapse, and a lot of blasts and all the chemotherapy. So if you really want to have a good program, maybe this is also something to get used to, and then you slowly add on. Don't start with haploidentical transplant in the beginning. Then everybody is frustrated and disappointed about the outcome, and the team is, you have to get the motivation. It was a bad luck with your first patient. I mean, it went very well the first days, but this patient who had this pneumonitis or whatever, this patient would have had the same problem in any transplant center of the world to save this patient. And hemorrhagic pneumonitis. So this is fate. This is something nobody can predict this. But I think this would be my look for now in Germany, for example, or in our area of the world. If we have a child with maybe in the age of 3-4 years, we would give a med sibling transplant automatically nowadays as an indication, instead of long-term infusion and get all the problems. We would even do matched unrelated, but I think you have limited access and it's also expensive. So stay with matched sibling at the moment to get used to have the team ready, the nurses, everything. And you don't expect that many complications. You still have to be on high alert, well, of course, but there are not that many complications.
Okay, thank you. Please give some applause for the speakers. And then thank you for very fruitful discussion and many knowledge, many new horizon that we got for this event today. So maybe we need the session, then I hand it over to the moderator. Thank you, Prof. Viju and Prof. Robert.
Thank you very much. Before we end the session, please remain at the stage because we have two photo session. Umas, siap. The first two speakers and moderator on the stage. Nanti sesi kedua, speakers dan moderator bersama dengan para peserta. Jadi para peserta nanti bisa merapat, akan diambil foto dari atas panggung. Oke, terima kasih. Please return to your seat. And then the next session. Kami persilakan kepada peserta untuk merapat ke tengah join with the moderators and speakers. We will take the photo from the stage. Yeah, go ahead, sir. Yes. To the stage with the participant. Silakan merapat semua peserta. Ayo, boleh ke tengah. Oke, terima kasih. So the webinar, the international webinar today is over. Thank you very much for your kind attention. Good afternoon, selamat sore. Wassalamualaikum warahmatullahi wabarakatuh.
You can share your slide.